to be able to speak at GOPIO's first health summit. And to have Dr. Ramidhar introduce me is actually, it's humbling for the work that he has done over his lifetime in the world of cardiology. Dr. Ennis and his major contributions in understanding the extraordinary impact that atherosclerotic cardiovascular disease has on the Indian diaspora is, to say the least, inspiring in terms of being able to recognize the devastating impact that atherosclerosis, cardiovascular disease has on our community. In addition to understanding how devastating that impact is, it's really a message, a seed, a call to action, if you will, on our ability to understand what contributes to that risk of developing atherosclerosis and the impact of atherosclerosis on this, in this near and dear patient population. And what's actually absolutely impressive in their work, combined over several now, well, I won't date you guys, but a couple of decades at least. The bottom line is that they do extraordinary work in being able to educate all of us and the people that we represent in our own communities about how we can make a difference. It is about a call to action, a change in the way we must address every single risk factor, every single event that takes place amongst our friends, our families, and the patients that we're involved in providing their care. The work that you have done is honorable. Thank you. So I get about 20 minutes to be able to spend a little time talking to you about an incredibly devastating disease state in the patients that you and I take care of, that are near and dear to us, and the patient population, if you will, that represents us as a population in the world. The Indian patient population clearly has an overwhelming prevalence, you can go back to the first slide, overwhelming prevalence of atherosclerosis, and our ability as a population of people worldwide to acknowledge this overwhelming prevalence is critical. Why? Because this disease state has extraordinary implications on morbidity and mortality in our people. Extraordinary. And when we go over the numbers in just a brief review of the epidemiology of this particular entity, it's devastating. We must also recognize that not is this just a disease state that has overwhelming implications in numbers, but we even understand how this disease state impacts us. We know the risk factors that are contributing to this risk. We understand some of the pathophysiologic states that exist today, and we can potentially, by identifying and recognizing those risk factors in the individuals we're taking care of, make a difference by making the right choices. We know that in our own people, in our own population, that many of the traditional risk factors that you and I recognize, whether it's high blood pressure, whether it's cholesterol problems, whether it's somebody you know that is smoking, just by virtue of being a member of the Indian diaspora, those risk factors have a magnified influence on outcome. Magnified influence on outcome. How magnified, we'll talk about in just a few minutes. We also must recognize that amongst all of the clinical risk factors that exist that have an absolute devastating impact on outcome, dyslipidemia is one of the most powerful risk factors that people have. And in our patient population, in our public, we must recognize the value of this risk factor. And I think recognizing all of these risk factors, knowing the pathophysiology, and recognizing how important being aware of these risk factors and the influence on outcomes mandates the embrace that has been inspired by the good works of the folks that have spoken before me. And that is, we must be aggressive. It is no longer time to wait. It is now that we must act to be able to recognize and influence the critical nature of these risk factors and the influence that they have on the negative impact on outcome. Yes?
There are lay people here. Could you please dyslipidemia is?
Absolutely, and I apologize if the slide is not clear. So dyslipidemia is abnormal cholesterol or lipid, fatty panels that we essentially, fatty mechanisms, if you will, of deposition in our arteries. So dyslipidemia is abnormal cholesterol. Okay? That's sort of the simplistic way to go about of understanding it, but that's clear, and I appreciate the opportunity to express and clarify that. So let's just take a couple of minutes and talk about this enormous disease, enormous burden of this disease state. The annual death rate from heart disease in India is rising over the last 30 years. There are estimated to be over 2.3 million deaths due to heart disease in India, in Indians, I should say, alone in 2010. 2.3 million deaths. What is, that number, somebody says, well, there are a couple billion Indians around. Who cares? It's not a big deal. Except for one thing. In this most talented group of people, the most inspiring, one of the most successful ethnic groups in the world, 30% of the deaths that are occurring are in people less than the year of 40. 900 people, Indian people, are dying from heart disease every single day, and they're under the age of 30 years. It's devastating that this disease state influences these young people at such an extraordinarily alarming rate. The dollar value of lost productivity, of lost success, is enormous. Hundreds of millions and billions of dollars being lost due to one of the most preventable disease states in the world. And what is interesting is that, we are an inspiring people. We have the ability to influence many nations, many ethnic groups on how we understand this disease state. And yet, in our own patient population, in our own public, we're not able to make a difference in the youngest of youngest people? That is absurd. It is not a challenge that we cannot meet. It is a challenge that we must be inspired and absolutely committed with passion to meet. In India, why is it that everywhere else, the US, Canada, and other major nations that are developed, the death rates from heart disease are falling 3 to 4% per year? In India, it's rising 6 to 7% per year. Rising. When we have treatment strategies that are available that make a difference on outcome. Is it because we're not aware? Is it because we don't understand the pathophysiology? We're one of the most talented groups of people in the world. We understand the pathophysiology. Many of us are involved in the research that define the pathophysiology and are looking at the cures. And yet we're not embracing this as a patient population, as a public. Next slide. So that we can take a look at being able to recognize that death rates compared to other ethnic groups are extraordinarily high. 50 to 300% greater compared to other ethnic groups. It doesn't matter whether you talk about Eastern Europeans. It doesn't matter whether you talk about the Americans. It doesn't matter whether you talk about other Southeast Asian countries. The bottom line is that Indians are dying of heart disease in a much, much greater rate and cannot be accepted. In the last 4 decades, the prevalence of cardiovascular disease in rural India has doubled. And in urban India has quadrupled. And what is interesting, and probably one of the most influential variables, and I think this is attributable all to your data and your work in understanding the epidemiology of this entity, and that is that for any given risk factor, the impact that that given risk factor has, whether it's hypertension, whether it's abnormal cholesterol, whether it's smoking, that amongst the Indian patient population, if you compare it to every other ethnic group has a morbidity and mortality associated with each and every given risk factor. In Indians, by virtue of being Indian, it's doubled that magnitude of risk. Why? We need to understand that. And we can no longer tolerate inaction. Must be embracing action. So, what we want to be able to spend time on today is understanding that all of these key risk factors, whether it's the lack of physical activity, that means my dad coming home at 5 p.m. after a hard day's work, starting at 6 a.m., and sitting in front of the television, waiting for dinner, reading the newspaper or watching the news. Not exercising. Whether it's somebody lighting up a cigarette. In India, 30% of people under the age of 30 are smoking less than a half pack of cigarettes a day. 30% of people less than the age of 30. That's huge in that country. Worldwide, that number is falling. In India, that number is rising exponentially. Why? If you talk about obesity, or for that matter, diabetes. Diabetes is a raging epidemic worldwide. And in India, it is absurd the rate at which the number of diabetics are growing. Absurd. Diabetes, by virtue of its implication on the blood vessels in the body, is essentially an equivalent to atherosclerosis. The impact that that disease state has on the influence of myocardial infarction, stroke, and death is extraordinary. In Indians, no matter where you live, you are not immune. You are at the highest risk for developing this disease entity and its implications. High blood pressure, age, dyslipidemia. Next slide. All of these risk factors in Indians are magnified in its impact on outcome, morbidity and mortality, by one lipid factor. And that is not just the bad cholesterol, the LDL. It is lipoprotein A, little a. LP little a in Indians occurs, or is prevalent, for every 4 Indians, or every 10 Indians, 4 Indians have elevated lipoprotein little a. One of the many lipid particles that are so atherogenic, so inclined to create plaque in our arteries, that it portends an enormous risk of heart attack, stroke, and death that compounds every one of these traditional risk factors in orders of magnitude that you and I can't even pretend to think about. And we are at risk just by being us. It's extraordinary. This risk, this incidence, this prevalence of this disease state is absolutely absurd in this patient population, in our public, that has such a dramatic negative impact. If we take a look, next slide, at all of the non-lipid, non-cholesterol risk factors, whether you talk about smoking, obesity, physical inactivity, atherogenic diets, diabetes, or hypertension, you take any one of these individually, they have an impact on morbidity and mortality. You magnify that morbidity and mortality impact in the Indian patient population in its association with lipoprotein little a, and by virtue of who we are. If you take a couple of these, a cluster of these risk factors, how many diabetic patients are also hypertensive? In the Indian patient population, nearly 80% of diabetic patients are also hypertensive patients. The magnitude of risk is again explosive in nature, and its impact on morbidity and mortality is dramatic. Dramatic. Let's take a look at some of these individual non-lipid risk factors and its impact on morbidity and mortality. How about body mass index? One of the most criticized measures of understanding body habitus. There's literature all over the world, in the cardiovascular literature in particular, that suggests that BMI should never be measured. Why? Because it doesn't necessarily reflect percent body fat. It doesn't necessarily an accurate reflection of some balance between height and muscle mass. But the bottom line is, independent of all the criticisms, as body mass index increases, as your BMI increases, whether you're male or female, your risk for heart disease, mortality from heart disease rises.